Hello, everyone. My name is Pete Weber from the Virginia Tech Carilion School of Medicine. Thank you to Neil, Jessica, and everyone at the foundation for inviting me to give this talk. I will be presenting my work from the Therapeutic Ultrasound Lab at Virginia Tech on histotripsy for cholangiocarcinoma liver tumor ablation, ex vivo and in vivo feasibility studies. Histotripsy is a non-thermal focused ultrasound ablation method that has shown promise for treating liver tumors. A phase 1 clinical trial demonstrated the feasibility of treating liver tumors with histotripsy. However, there have been no studies to date looking at the treatment of cholangiocarcinomas with focused ultrasound. Cholangiocarcinomas are a rare subtype of liver tumor that arise from the epithelium of bile ducts. These tumors have a dismal prognosis with a 5-year survival of only 8%. Few of these tumors are resectable at the time of diagnosis, and alternative treatment options are limited due to their frequent location near large bile ducts and blood vessels. I'm going to present here our study to investigate the feasibility of histotripsy for treating ex vivo and in vivo cholangiocarcinoma tumors. Ex vivo tissues for this study were harvested from patients with a resectable hepatocellular carcinoma, liver metastasis, or cholangiocarcinoma that were enrolled in an IRB-approved study. All 3 of these tumor types were treated with histotripsy to compare the ablations of cholangiocarcinomas to the other liver tumors. Secondly, a human-derived cholangiocarcinoma xenograft mouse model was used to test the in vivo feasibility of histotripsy ablation for cholangiocarcinoma tumors. A schematic of the treatment setups is shown. Briefly, for ex vivo tissues, resected human tumors were embedded in gelatin tissue phantoms and ablated with a 700 kilohertz clinical histotripsy transducer with 5-cycle pulses and a pulse repetition frequency of 500 hertz. Varying dosing parameters were tested, ranging from 250 to 4,000 pulses per point. The in vivo experiments were performed with a 1 megahertz small animal transducer with 1-cycle pulses and a pulse repetition frequency of 500 hertz. Videos from both the ex vivo and in vivo treatments show that bubble cloud formation is possible within the cholangiocarcinoma tumor. The ex vivo video also shows one of the limitations of this study, that the bubble cloud size was generally larger than the tissue samples that were resected. We were able to attain a complete ablation for hepatocellular carcinoma tumors treated with a dose of 500 pulses per point and above, which is consistent with previous studies. Most treatments above 1,000 pulses per point were able to achieve a complete ablation in colorectal liver metastases. However, there were a few subtotal ablations, mostly due to heterogeneity within the tissue. Cholangiocarcinoma tumors were treated up to a dose of 4,000 pulses per point. Even in the tumors with the most damage, there remained regions of intact tumor corresponding to the more fibrous regions. We expect that a more complete tumor ablation of the whole volume would be observed if even higher doses were applied. Alternatively, larger tumor samples would avoid some of the experimental error mentioned previously caused by the prefocal cavitation in this ex vivo model. One of the advantages of the in vivo mouse model that we studied was that the small animal transducer was able to reliably maintain a bubble cloud within the tumor. The human-derived xenograft was also chosen to mimic the dense fibrotic tumor microenvironment that is characteristic of cholangiocarcinoma. Initial results have demonstrated that ablations were achieved at each of the 3 doses investigated, with complete ablations achieved after doses of 500 pulses per point. In conclusion, our study has demonstrated initial feasibility of cholangiocarcinoma tumor ablation with histotripsy. The comparison with other liver tumors suggests that higher doses will be needed for cholangiocarcinoma ablation. Further studies are needed to determine the clinical utility of histotripsy ablation for these tumors. And one question is whether a complete ablation of cholangiocarcinomas will be possible near large blood vessels and bile ducts. Additionally, we are interested in learning whether immunomodulation with histotripsy can be harnessed for these tumors. And with that, I'd like to thank everyone at the Therapeutic Ultrasound Lab at Virginia Tech, especially Eli and Alyssa for their help. We would like to specifically thank the Focused Ultrasound Foundation for funding this work, as well as their other support for the lab. And thank you to all of you for listening to this talk.